Okay, so today is a new iteration of the UCL's Global Business School for Health's webinars on reimagining business and management for a healthier society. So this is a webinar series that GBSH runs, which brings together thought leaders from across the health ecosystem, which is really a broad spectrum of different experts from different walks of life. My name is Kabir Sheikh. I'm a professor of global health systems and policy at the UCL Global Business School for Health. Just to let everyone know that the webinar is being recorded and it will be made available after the session, a few days after the session. So today's webinar is on health workforce heterogeneity in low and middle income countries, conceptual and practical considerations. We've got a really great lineup of panelists for you, and we also want to keep it really interactive. So we're going to ask our panelists to come in with short, sharp interventions and then open it up for questions. We have Vivian Lin, who is Executive Assistant Dean at Associate Dean at the Lee Kuan Yew School of Faculty of Medicine, University of Hong Kong. The Li Ka-shing Faculty of Medicine, University of Hong Kong. We have Micah Schleif, the scientist at the Alliance for Health Policy and Systems Research. We have Dr. Hawi Liwanag, who works with the Alliance for Improving Health Outcomes in the Philippines and also is a postdoctoral fellow at the University of Bern. We have Samuel Lassa, who's a general practitioner and clinical researcher at the University of Jos in Nigeria and also works at the Royal Primary Care, Derbyshire. And we have James Campbell, who is Director for Health Workforce at the World Health Organization. Can we have the next slide, please? The previous one, please, Anil. So this is just a quick run through of the order for the day, just so that you know how we're going to plan the 1 hour. We will have the panelists speaking in turn. And then we'll have a question and answer session for hopefully 25 minutes. We'll need to close a little bit before the hour. Please make sure you enter your questions in the Q&A option and not in the chat box, and then we will take a look and try to ask as many questions as we can from the list that we have there. So now, on the next slide, please. So when it comes to the diversity of the health workforce, I think many of us have worked on these issues for a long period of time. And we've come to realize, of course, that there's more to the health workforce than a group of peacefully coexisting doctors and nurses. And in fact, the workforce is so diverse that no one has actually fully made sense of that heterogeneity and what it actually means, what it implies. Nobody's developed a very effective typology of that, the full diversity of the workforce. And this was a rather rudimentary attempt that we made back in 2017. This paper got published in the BMJ Global Health, which tries to make some sense of this heterogeneity. And I looking back on it, like 9 years ago, I think we did a decent back of the envelope job, but I still think there's a lot to be required in terms of how we frame this heterogeneity effectively. But a few things to note here. I mean, you look at the different axes that we've created here. There's, of course, the binary that's often mentioned between the public and private. And then there's also, of course, a whole spectrum of providers from highly specialized to care workers and lay workers who are often unpaid. And then we have we can also look at that in terms of a spectrum of recognition, which is that there are some healthcare workers who are formally recognized and legitimized by the state and by authorities, and others who are not, and generally lie outside of that domain. And then, of course, the other big binary that's often created is the distinction between Western biomedicine and various traditional and local forms of medicine and healing, which also coexist with allopathy. So I think one of the key things to note, the three key things to note in this figure, and the first is that the figure doesn't identify these as binary categories, but rather as spectrums. Because there's a lot of mixing across each of these. There's sometimes it's difficult to, even between public and private, it's, there are various different forms of public-private partnerships or private behavior in public sector, public behavior in the private sector. And similarly, all of these represent a spectrum rather than binary categories. The other thing, and which is really at the heart of what we are going to talk about today, is that this heterogeneity it doesn't imply that all of these groups are coexisting peacefully and harmoniously and delivering services in their niche. There are a lot of contestations and micro-politics and macro-politics between these different groups of providers. And that in particular creates governance challenges for any policymakers in terms of how to manage this diversity, how to leverage it effectively, but also how to sometimes to regulate and to steward effectively. So if we are really to take forward, and these are real world challenges that are faced by policymakers all over the world, and if we are really to help them in taking forward this governance challenge, we need to do a lot of work. I mean, as some of us are scholars, and as scholars, we need to do more to develop this field conceptually and to understand it better. But we also need a much better practical understanding of how to tackle these challenges. So having said that, that's a brief introduction to heterogeneity, but this is, as I said, back of the envelope. But we have with us the Director of the Health Workforce at WHO, James Gamble, who's going to give a much more supported and cogent explanation of this heterogeneity, and I will hand over to him for his presentation. Over to you, Jim.
Thank you very much, Professor Sheikh Kabir. A pleasure to be with you today, and I'll try and be as timely as possible and trying to set out and build on what Kabir has just presented from the 2017 paper. We're just going to quickly go into a bit of definition and a bit of data before the panelists come in and give us some exemplars and case studies of their work as well. And just to come and look at this broader understanding in 2024 of the health and care workforce. Next slide, please. So what are we looking at? We're looking at health workers, we're looking at care workers, we're looking at health and care work, and the millions of students worldwide that are in education and training to become health and care workers. All of that is part of our today's workforce or tomorrow's workforce in terms of our population of interest. These have been well defined by WHO and the International Labour Organization in terms of these categories. And just to understand, around the world today, we have 2/3 of countries now have a mandate for health and care. Nearly half of them are starting to introduce that into their titles. So it's the Department for Health and Care or the Department for Health and Social Care. So they're coming further forward. So they're looking at this whole integration of health and care services, health and care work, and who are the health and care workers. And this differentiation between work and workers has to be understood, because there are many people whose work may not be being salaried, remunerated, compensated, either in a care role for the family, in a self-care role, or in a care role for the community. And if you look at the entirety of this, next slide, we're looking at building an appreciation for more than 140 million health and care workers, maybe 100 million health and care people who are working in health and care but not necessarily considered workers, and then maybe 10 to 15 million students worldwide. How are we doing that? 10 years ago in Recife, Brazil, at the 3rd Global Forum on Human Resources for Health, clear set of evidence was tabled as we went into the SDG period from 2016 to 2030. The need that we had to better understand the workforce and our population of interest through data. There was a whole discussion on the absence of data. A technical working group was formed that fed into the global strategy in 2016, the High-Level Commission in 2017, Working for Health program, resulting in the launch of national health workforce accounts. In 2017, of course, global human resources part. As a result, next slide. As a result, what do we have? We've seen this huge increase from 2013 to 2023 in the availability of unemployable data. We've got a 5-fold increase in the stock, but a 20-fold increase in terms of describing the workforce, its education, its labor policies, the attrition rates, the turnover rates. So we've got a much, much stronger position 2024 to be able to be having these discussions. Next slide. This process is validated by member states. So it is reporting by member states through a national health workforce focal point into the data platform, a standardized data platform for all countries around the world. Data triangulation and validation, looking at comparisons, making sure we're integrating labor force surveys, integrating other labor market analysis work to try and build this best possible picture around the world. And over 190 countries, territories, and areas are now participating in terms of the latest updates in 2023. So from a standing start 10 years ago at 190 countries and territories engaged, giving us a much better interpretation. And then next, what's the impact of this? We're able to produce, we're able to produce national reports which are putting their data into the public domain. Next, regional reports where we aggregate those national data either at the European level, the African level, the Western Pacific level, to start to look at some of the similarities and comparisons. And next, at a global level, some of the particular areas, looking at particular occupations, nurses, midwives, oral health, looking at the entirety of the information. And this is building a global repository of knowledge. It's in supporting science, workforce science research to actually utilize this validated data and put it into policy practice, technical issues. Next slide. Let's give you some examples then of what this public good is. Around the world, like I said, we're looking at approximately 140 million workers. Next. Of which just under half of those are in the major workforce, clinical workforce occupations, the big 5 that we often talk about. They're distributed around the world, those big 5 occupations, and we can see this sort of geographical distribution on some of the inequalities that are highlighted through that. Next. And then we can start to look against this 140 million. We can pick one occupation and start to look into a bit more depth. And several of the panelists are going to be talking about the role of community health systems and the workers in those systems. So we picked, just as an example, see community health workers here, 4 million, 2.9% of the entirety. Next, let's look at a bit more depth. 4 million, where are they? Next, half of those, just under, in 2 countries, one, India and China. Where this has been a huge populations, therefore greater number representing a significant share of it. Next, let's look at Africa. About 20% of the CHWs in the world in the African continent. Next, break that down. Let's look at the latest initiative on community health systems from the US government with UNICEF, looking at 16 countries. They've got about 10% of the community health workers. And what are those workers doing? Next, we just don't. Are they paid? Are they employed? Are they full-time equivalent? Or are they, as we saw in the various spectrums that Kabir presented, we've got informal and formal, lay and specialists. Where are they on this spectrum as workers doing work? Next. So this public good is available to anybody. It's online. You can access it through the WHO Health Workforce, the National Health Workforce Portal. It produces query tables, information that you can extract and utilize for any particular question that you may have. So as we're diving into this whole discussion of the heterogeneity, this data is available to inform you. And it also gives you the information on the strength, the quality of that data. So where is the strength of the human resources for health information system? What is the frequency and the reporting? What is the additional analysis and the validation of this? So you can have some sense of how strong can your recommendations be based on the quality of data that you're looking at from member states. Next. So this work is, I just want to recognize that it is it's a 10-year period from concept to where we are today, 190 member states and countries. It's people at the national level bringing this data together, getting it validated, submitting it to WHO, putting it into the public domain for policymakers, research scientists to utilize to inform evidence-based practice. And what we're particularly excited as WHO, working with UCL, working with Vivian in Hong Kong and others, is to make sure we really lift up workforce science, that into 2024 and beyond, we have a rigorous workforce science approach based on empirical data, based on comparable statistics across the world, to be saying if we're talking about one particular group of workers in a country, we can compare and contrast accurately with others to be able to look at the particular characteristics and then have context-specific policy recommendations, not global recommendations, which may not be appropriate for context. Thank you very much for this. Back to you.
Thank you, Jim. So that's the National Health Workforce Accounts, and that's such a fantastic resource. And I think it really reflects the progress that WHO and partners and the whole world has made in putting numbers to some of those categories that we showed earlier. And, 10 years ago, we didn't have all that. So please do access that resource. Also, Jim, very strong plea for workforce science. I think we'd all back you on that. I think it's such an underappreciated field, and yeah, we're all kind of working in that space. So thank you again. And we're going to now move to a series of quite specific case examples just to illustrate some of the specificities of these governance challenges and aspects of heterogeneity. So we're going to start with Samuel Lassa, who's done some amazing work in Nigeria. And over to you, Samuel.
Thank you very much, Professor Kabir Sheikh. Thank you for the opportunity, and thank you everyone for coming. So I think focusing on the heterogeneity, I think one of the main things I'm going to talk about is medical dominance and medical dominance in the health system and how that affects health policy making. So I think the first thing is to just introduce what we mean by medical dominance. And when we talk about medical dominance, we're talking about medical professionals. I'm a doctor myself, so disclaimer. So medical professionals are regarded as the pioneer occupation in the health sector because of their historical origins as being the first health occupation with any recognizable formal education, which some have pointed as the reason for them being top of the health occupational hierarchy. And when we talk about medical professionals, we're talking about Western style or biomedical based type of medical professionals here. So some sociologists have actually cited the role of medical professionals with their ability to be able to help the ill person, because the ill person is helpless and lacks the technical knowledge to help himself or herself. Therefore, the ill person relies on professional authority. And that's where in society, medical professionals have got that power and that influence in the health sector. But I think other sociologists have actually focused on four main areas, which I'll just briefly mention, and then I think other speakers will touch on on these aspects. I think the first one is the division of labor. Medical professionals have been able to have that kind of monopoly of division of labor, which means their ability to determine the terms, conditions, goals, objectives to which professionals are accountable, to which their professionals are accountable and are able to establish boundaries and jurisdictions within the health sector. Also, controlled labor markets, which means that medical professionals are not subject to market laws of free and open markets in the sense like other professionals, in the sense that they're able to determine the qualifications that are needed for a certain task that needs to be carried out in the health sector, regardless of the organization. Then they have an occupationally controlled training where they're able to have the luxury of accrediting only certain institutions to be able to produce the medical professionals who are the leaders in the health sector. But I think one of the main things I wanted to focus on today is the professional ideology, which is the medical professionals' certain code of conduct and ideology, which aids their persuasion of the public and state to see their significance in society, which is where the dominant biomedical ideology comes, which forms the foundation of most Western-style medicine and is usually the dominant way of thinking or rationalizing health globally. So most policymakers know that the dominance of only biomedical thinking in governance and conceptualization of policy design in low and middle income countries is a limiting factor. And a lot of global health organizations actually try to reduce that and bring up a lot of initiatives. So an example which I'm going to focus on is the Global Fund. And the Global Fund, aware of this dominance of biomedical dominance in the health policy spaces, have tried to limit it and promote heterogeneity by creating something called the Country Coordinating Mechanism, which is a platform to bring in non-medical stakeholders to help in diversifying and improving heterogeneity in the policymaking spaces for the Global Fund. But our empirical study, which focused on the Global Fund grant activities in Nigeria, looking at how they develop proposals and how they lead to implementation, found out that these platforms, the country coordinating mechanism, which was meant to increase diversity, was actually captured and became a foundation to how medical professionals were able to dominate the policy-making space. And they did that through three main ways. Through positional power, because most people said that medical professionals are the drivers of proposal processes, and their views often supersede those of other non-professionals. So patient groups and local community-based organizations actually just let them take the lead and felt that their biomedical discourse was more superior to their own perspective. So they felt they couldn't get involved in that deliberative processes. And then the use of biomedical language, which overshadowed the discussions. And most times the biomedical language was used in focusing on topics that were not even really medically related, but biomedical language superseded. That meant medical professionals took the lead. And then the last one, which I want to mention, is the structural institutions. So I know I have some people from WHO here and some other leading organizations, but the preference for biomedical based interventions or proposals actually made people focus on what doctors had to say when it comes to the proposals, and actually made them have a more prominent role. So I think here the intervention that I think would help to improve or diversify or improve heterogeneity is for us to allow active participation of both patient populations and other non-clinical professions. We need to be able to sensitize the non-health sector and remove some structural barriers that create a rigid system. Some focusing on only biomedical technical guidelines during policy deliberations. I think that would improve the health dialogue and make it more diverse and heterogeneous. And I think that's the intervention that our study or our group is recommending.
Thank you so much, Sam. So very nice kind of overview on how the health sector and health systems are sort of made in the image of the most dominant of the groups within them, who are the doctors and the medical profession. And then, of course, there's so many implications and ramifications of that. But I think that sets us up nicely for the next intervention from Vivian Lin. Over to you, Vivian.
Thank you so much. Thank you for the opportunity to be part of this conversation. I want to offer a perspective coming from the Western Pacific region. And it's about the place of what might be called traditional, complementary, and integrative medicine And the first point is, in fact, these constructs are actually quite fluid because of context. So in some places, something is traditional, but that particular modality becomes complementary in another context. And sometimes it's indigenous, and then it becomes integrative. So the first point I want to make is that within most health systems, you've got some form of traditional complementary or integrative medicine. But these actually shift because of the nature of the community and how they use health system. And so to do anything from a policy perspective means firstly understanding the health system context, but more importantly, understanding the community and how it goes about choosing to see particular types of practitioners. And at the heart of this is, who do they trust? So then, second point, if you want to think about health system response and health policy response, then you need to be clear about what is the basis for actually making healthcare decisions. Now, in most health systems, when you think about formalizing the roles and contribution of particular health professions, you think about whether that profession might require some sort of intervention in order to protect public health and safety through standard setting, through a more standard education to ensure quality and regulation. And by doing so, you may be able to extend the access and the quality of services. And insofar as most of these practitioners are frontline service practitioners, we're really looking at extension access to primary healthcare and therefore part of universal health coverage. But how you go about this, again, may be different. So let me give you a couple stories from the region. Many people might think about Chinese medicine as something with a very well-established system, thousands of years of history and knowledge base. But the reality is Chinese medicine in China, while indigenous, did not get put on what I would call a regulated platform until 1960. So it's very, very recent phenomenon when there was a decision taken by the state to actually move the teaching of Chinese medicine from an apprenticeship-based model to an educational institution model. And by doing that, for the first time, consideration was given to what is a curriculum? How should it be taught? And so at the time, there was actually no practitioner who taught in this formal kind of setting. So it was actually Western medicine practitioners who then helped develop the education. And in some ways, the education of Chinese medicine in China, therefore, grew up in a Western medicine education model, right? So here we are looking at the complexity. And then in the 1990s, there was a lot of interest in Australia to consider whether Chinese medicine might be a registered health profession because there was widespread community usage. And so herein was an interesting debate where the Western medicine leaders, open as they were quite concerned about, does this mean the government is endorsing the efficacy of Chinese medicine when, we really didn't have a substantial knowledge base through randomized clinical trials? And the minister at the time said, the evidence shows that the state needs to step in to protect public health and safety. That efficacy was actually not a concern for the government, but it was the fact that people were using quite widespread. Indeed, the evidence showed that most of the users were tertiary educated women. And they were using Chinese medicine, as well as Western medicine. And the profession itself could not agree on an educational standard, could not regulate, because each time people fought, another association was created. So in thinking about professional self-regulation, it was not possible. And therefore, the government saw that there were risks. They analyzed the reports from the court system to look at deaths, which had to be investigated. They looked at database that covered adverse events and saw that there was a real risk in terms of using both Chinese medicine and Western medicine. So here you have an instance where what people in biomedicine, the dominant perspective, as Sam spoke about, concerned very much about efficacy, but that was actually not the basis. It was this community usage. So then if I bring in a Pacific Island, Samoa, they decided to regulate allied health workforce as part of the total picture. But here, traditional healers are very much the front line. But how do you define all the different categories of traditional healers and what should be regulated and what should not be regulated? And in particular, you have very high levels of NCD, such as diabetes. And so it was very, very unclear whether the traditional medicine and the dual use was actually helping or hindering. They had a model where traditional birth attendants, they developed very good protocols and training to link midwives and traditional birth attendants. But how do you do that with the rest of this very heterogeneous workforce in a community of 200,000 population? So this is the second consideration of recognizing that trust in the community is important, but the government has to have a clear framework, which leads me to my last point, which is when we start to think about these different low and middle income countries, the core of the issue is what is a fit for purpose workforce and a fit for purpose health system, and one that really does build on the trust of the community and ensure that the community is well protected and does have access to quality and safe services. Thank you very much.
Thank you, Vivian. I think in 5 minutes, you really covered a sweep of concepts that we need to tackle with, which confront us as researchers and policymakers. I think these categories are so fluid depending on the context in which they lie. So it's really difficult to put a pin on any particular category of health worker and say, this is what you are, and that's typified in your examples. And then, of course, the big tension that governments have between regulating for safety and efficacy, and on the other hand, the importance of trust and closeness to communities. And I think that's, again, something we highlighted in the framework, that often the least sort of mainstream providers are the ones that are closest philosophically, physically, to the most marginalized communities. So it's a kind of a paradox. Lots to think about. And another similar group of providers, well, not similar, but also on the right side of the spectrum, the sort of close to community group of providers is what Micah Schleif is going to talk about. Over to you, Micah.
Great. Thank you, Kabir. And it's really a pleasure to be here with you all. I hope I can pick up on a few of the themes and points that Sam and Vivian have already mentioned. And I think that there's obviously so much that we could say about community health workers as well, because there's also such a diversity around the world. And I think if you look at countries from the United States down to a country like Haiti, so high income to low income, but grappling at a very fundamental level with some of the same challenges, which is particularly how to extend quality care services to at the community level. we see a range of workers that have sort of been given the title of community health workers, and some of them, a chunk of them, I would say, are, could also be fit into the traditional worker category and may have been that at first, and then also be recruited and trained as community health workers. Many nurses in high income contexts such as the United States also take on community health worker titles and roles, which include more care coordination and community outreach. And then you have countries like Ethiopia that have really established formal professionalized community health worker cadres who are civil servants, who are salaried and have that formal community health worker title. So it really is a huge pool of workers, and I think much remains to be understood, even just in sort of enumerating them and understanding more in depth, how they fit within the health system. Because I think the first point that I would like to make is that they're often at a very, community health workers are often in a very important sort of interface between provision of primary care and sort of connection with the rest of the health system, and then often being part of and really having that sort of thumb on the pulse of what communities need. But I think there often ends up being sort of a tension of both where does the majority of their work lie? Is it more health post based or outreach from a health post trying to extend sort of more clinical health service kind of activities, or is it more of a community-based role, helping to bring community perspectives into planning decision-making of the first tier of a health system? And so, and oftentimes, the workers end up having an emphasis on one side or the other, and that's really understandable. One approach that's been taken to, I think, try to address that, in addition to many other considerations as well, is having dual cadre community health worker systems. One example of that, and there are many, or a number, is Ethiopia, where they have a professionalized, salaried community health extension worker cadre that's more focused on, they're based in health posts, they do outreach work and spend time in communities as well, but their primary role is more sort of clinical and preventive and promotive health service provision. And then they have a cadre of the Women Development Army, which is really focused around mothers working in their communities with peers to really focus more on promotion and activities like water and sanitation and child nutrition and things like that in a peer support role, and those are volunteers. So that's one way of doing it. There are obviously, I think, a number of challenges there, including sort of workload and equity in terms of who's being paid and who's not, and really being able to understand how to navigate through that. And also, I think one of the tensions that we're seeing in Ethiopia, which is, I think, a discussion in a lot of other contexts, is, if you start your journey as a health or care worker in a community health worker role, particularly a role like the Women's Development Army, working with your neighbors, working to improve your own household and your own family's well-being, what and whether there is then a career pathway into being a health extension worker, being a nurse, being in some of those other health professions. And there's certainly active work in Ethiopia, and I think in a number of other contexts, to try to sort that out. But that hasn't been a very clear and sometimes not even really an option for that sort of progression. That relates to sort of training challenges, which is the second kind of bucket of opportunities and challenges, I should say, that I would like to bring up a few issues around. And one is, again, sort of that trajectory of, many community health workers, especially, in the last couple of decades, have been recruited from communities. The expectation of sort of literacy and other prior sort of academic training has been fairly limited in order to be able to really work with community members who have that invaluable perspective and connection with communities. But then if you want to provide opportunities for that sort of career advancement, then some of those other skills of literacy, potentially some mathematics, other things also need to be developed in parallel, and sort of how to go about that. I think in many settings, there's also been a challenge of training being really fragmented. And so sometimes there's a core curriculum, but then also, how does the refresher training happen? Is there sort of are there opportunities again for expansion of knowledge and sort of service provision options for those community health workers? And then in many contexts, if you look more at a country like Haiti or perhaps Tanzania, much more focus on sort of disease-specific training programs. So, an opportunity for community health workers to help with an HIV program or a TB program or some sensitization or efforts around screening of non-communicable diseases. But it doesn't always really hang together, and that doesn't always happen sort of consistently across a national or even a large subnational level. So really trying to help community health workers understand what is their role, how do these trainings fit together, how do they think about their profession as a whole, and that leads to my last point as well, which is around sort of workload and task shifting and appropriate remuneration for community health workers. And I think that's been a huge debate, and there's been a real push in recent years towards ensuring that community health workers are remunerated appropriately, and recognizing that many of them are very much overworked and often not paid very much at all, if anything. And I think it's not very black and white, and that's the challenge, because the workloads vary. The context in which community health workers are working, the expectations of what they need in order to live, have a good livelihood, also vary dramatically. But I think that that's really an important point as we consider going forward, starting with really understanding who is part of the workforce and enumerating them appropriately, but then also thinking through what is both an appropriate and reasonable, but also a sustainable way to remunerate these workers. And I think that it gets to some of the points that Vivian has raised as well, is that there is a bit of there is a continuum and there's a gray area, which I think from my perspective goes all the way from, mothers working within their own household and caring for their own family, which in most of the world is unpaid labor. But then is working with the local health system, all the way to having a really full-time professional role. So I think there are many complexities to work through, but I think we've seen in a number of countries, including countries like Ethiopia, Bangladesh, Brazil, and many others, the incredible contributions that community health have made, both in terms of service extension as well as in bringing that perspective together. So a lot of evidence that they really provide a lot. So happy to discuss when we get to that point as well. Back to you, Kabir.
Thank you, Mike. And obviously such a heterogeneous group of providers even within itself, the community health worker group. And of course, all of them human beings with aspirations and career intentions and, lives of their own. And that's something we often miss when we think about them as human resources rather than as human beings. So maybe how we can shed some light on how governments look at health workers. He's going to talk about his experiences with the Ministry of Health in the Philippines. Over to you, Javi.
Many thanks, Kabir, and I'll stick to my 5 minutes. I'll try. And thank you to the UCL Global Business School for Health for inviting me to this panel. I'm with the University of Bern in Switzerland, but I'm actually saying good evening from Australia in my current role as visiting scholar of the University of Melbourne. But tonight, I will refer to my time as a scientist in the Department of Health of the Philippines in 2019-2020, particularly in the Health Human Resource Development Bureau, which I had the distinct pleasure of working very closely with. And I think Dr. Mary Ruth Politico of the Philippines is tuning in, so I would like to recognize her as well. And the task given to us today is to interrogate this notion, and in fact, this reality of a health workforce that is heterogeneous. And from the perspective of a Ministry of Health, I think governance of this heterogeneity involves a range of functions that include planning, standard setting, regulation, training and development, etc. And the institutional capabilities to perform these functions inevitably will, as Jim Campbell has emphasized in the beginning, it will need data. And I think the questions are who, where, and how. Who exactly are the health workers that comprise the heterogeneous health workforce? And where are they? How do we assess if they are adequate in numbers, equitable in distribution, highly competent, well compensated, well protected, well recognized, and well motivated, so that this health workforce leverages on its heterogeneity to meet the health system goals of responsiveness, efficiency, quality, and equity? And with limited knowledge about this who, where, and how, I think from the perspective of a Ministry of Health, it would be quite challenging to govern this heterogeneous health workforce. So let me just maybe bring up 2 points. First, on the question of who and where. So when I look back at our work at DOH Philippines, we developed the health workforce strategic plan for the country, focusing on the licensed health professionals, namely physicians, midwives, nurses, dentists, pharmacists, and 5 other health professions. And there are 2 reasons why we were planning in this way. First, traditionally, these are the main cadres of the health workforce. And second, because there is a licensing mechanism for these health professions, we had the data readily available from the information system of the Professional Regulation Commission of the Philippines. So it was easier to plan for these professions because we had the numbers. Now, obviously, in a heterogeneous health workforce, there are other cadres that are not considered as health professions, and they may be outside the sphere of licensing. Community health workers, for example, in the Philippines, we call them as barangay health workers because they're not professionalized. They are not licensed, but they are counted in a separate registry managed by the Department of Health. Practitioners of complementary and traditional medicine, for example, acupuncturists, chiropractors, Chinese medicine practitioners, etc. They're also not licensed, but they go through a system of certification by the Philippine Institute of Traditional and Alternative Healthcare. So their data is in another database. So I think we need to engage and support ministries of health in LMICs so that when they plan for their health workforce, the planning goes beyond the conventional health professions. And that also means that there is a need to harmonize information systems that bring together data on the health workforce, both professional and non-professional, that will be readily available to feed into the planning processes of the MOH. That's because if we are not including other health workers into the plan, or perhaps in some countries we're not yet counting them, then that suggests that we are not even recognizing them as part of the health system. And I think that leads to poor governance of the health workforce. And it goes without saying then that when we do develop these health workforce plans, national planning should also include plans at subnational and community levels, especially in decentralized health systems. And that will require data not only on the numbers of health workers, but also on where they are, in fact, practicing and serving the community. And now, second, let me now touch on the how. I do think that the suite of approaches that we currently have to assess health workforce requirements, I think they do not consider enough the heterogeneity of the health workforce. So, for example, we have workforce to population ratios based on suggested benchmarks or thresholds of workforce density. We have service utilization or health needs approaches. And recently, we have the workload indicators of staffing need, otherwise known as WISN. All these approaches, I think, take into account the main characters. So that is the health professionals. And I think there is a need to think of new ways and approaches that estimate health workforce requirements, inclusive of the other types of health workers. And I think if we develop new approaches and methods towards this direction, then countries that use such approaches for planning will have to count the other cadres, the data of which then feeds into health workforce planning that will enable the ministries of health to be a better steward of a heterogeneous health workforce. And I will stop here. So thank you.
Wonderful, Harvey. I really like the metaphor of the main character. So I think what's coming out here is that we need to pay attention to the part-time actors as well, the extras, and make them not the extras, but also the main characters. So we have a couple of questions, and then we have about 8 minutes left. So I'm going to direct them to specific people. And then I think I might quickly ask one quick question to all of you. So I'm going to go with David Bishai's question first. Of all the heterogeneous cadres of workers, which one would most reward a ministry's attention, regulation, and stewardship? So if you were to choose and prioritize one cadre of workers, It could be for anyone. This panel. And maybe I can add another question so that you have a choice. So there's a question on the medicalization of policymaking, but also following up saying, how do practitioners determine the ideal skill mix occupations in the workforce that will be required in the future to cater to the health needs of populations within these subregions? Jim, please, over to you.
Thanks, and David, I'm gonna come back at you and be provocative on this. I think the responsibility of anyone in health workforce, health and care workforce, health systems, is to push back on that question and say, you need a team. It's a team of health and care workers, ministry that you need to be building for the future. The population needs, we need our anaesthetists, we need our surgeons, we need our trauma specialists, we need maternal, sexual and reproductive health rights, we need our community engagement. So focusing uniquely on one occupation, and I deliberately use occupations, not cadres. We're the only sector in the world that talks about cadres. Every other employment sector talks about occupations. You've got to push back and say the thing. The challenge, David, is that the average survival rate for a Minister of Health around the world today, 2024, is about 19 months before from appointment to dismissal or appointment to resignation or appointment to change of government. And so you've got to say, you've got to go beyond your tenure. Make sure that you do no harm, that you have no regrets, build the entire workforce for the future. Don't focus on one occupation. Thank you.
Thank you very much. Thank you very much, Jim, for that. I think just talking about the question where this asked for what is the best skill mix. I think one thing that we realize is that there was, in most low and medium income countries, there's the boundaries between the clinical space and the policy-making space is very blurred. And because of that blurred lines, we can understand that in the clinical space, there might be need for a certain structure and occupational hierarchy. But when it comes to policy discussions in Nigeria, in that context, that hierarchy also translates to when decisions or when interventions are being deliberated on, those who are higher in the clinical ranking always had more precedence in that discussion. But what our research was trying to say is that that space should be a place where all those occupational powers and hierarchies need not exist, because we found out that there's a lack of contextualization of most of the planning because a lot of voices that are local and contextual are not being heard. For example, I think Michael was talking about the community extension workers. Like in the health policy making space, most especially with the Global Fund grant, we'll realize that those voices are not even heard at all. But in effect, operationally, they're the ones who would actually give ideas on how to operationally implement most of these policies. So a lot of the thinking is very good and well-based, but for context and operationally, it doesn't work. So the policy making space and the clinical space was so blurred that policy making was always hierarchical and always driven by people who had more influence and power. And I think we were saying our paper was trying to emphasize that we need people that are more non-medical in that policy space and realize that they have a stake in it, rather than just leave it to one medical occupation, as Jim said, rather than cater to make all the decision making.
Thank you so much, Sam. So it's not only about function, but also about voice and place in the policy sphere. Vivian, please.
I like David's provocative question. and I really like Jim's provocative answer. I'm going to do one more provocation, hopefully for the next webinar, perhaps. Look, I think this issue about, is there one category of workforce gets us down to the issue of why do we have these categories? And are they the right categories? And, Western medicine is a relatively new phenomenon, in human history. But we seem to have this particular model that has been transported from country to country. And we see that in the global professional sphere, in the various professions, the discourse, the models, the education is also dominated by those professions from high-income countries, largely Anglophone countries. So many of the issues in these countries are played out. And so the kind of regulatory approaches that's in place may or may not actually be suitable for low and income countries, let alone the categories of the workforce. So I think there's a conversation to be had about decolonization. And it's about our approach to health workforce regulation. It's about our categories of health workers, and what's suitable for an island of 14,000 people is not the same thing of a country of 40 million people. So that's my provocation.
Wonderful, wonderful. So many provocations to take forward. And I think we have 3 minutes left, and unfortunately the webinar will close automatically. So we don't want to be cut short in the middle. So I'm going to give Micah the last response, and then I'll try and say something in 10 seconds before we close. But the conversation will continue. Over to you, Micah.
Great. Well, yeah, I guess I can make one more provocative point as well, which is that I think that we do have a lot of community expectations for, they want to see a doctor, whatever. But I think also, if we really look at especially younger generations and opportunities for accessing care through digital platforms, and also just expectations, especially if members have options of where they might seek their care, really focusing on providing quality of care, whoever's providing it, and also being able to think through how to provide services at a place and a time that's convenient for people, which I think for certain things, obviously not for everything, there are a lot of really opportunities to transform who community members can access and how to provide care through digital solutions as well. So lots of things to think about as we go forward.
Yes, digital is the elephant in the room, isn't it? And then one wonders whether it is also part of that spectrum of the health workforce. Javi, is it going to take a few seconds?
Yeah, just 30 seconds, maybe, because my intervention, I think, talked a bit too technocratic. So I was approaching it from a very technocratic point of view. And I just want to emphasize that in discussing this issue, we also need to politically engage. And that's important. Technocratic solutions alone will not address the issue. We need to politically engage as well. Over.
Wonderful, thank you. And last word from Jim seems to be that health workers are regulated, but health apps are not. So let's keep that in mind as we move ahead. And this is not going to be the last conversation we have on this topic, and this is not going to be the last conversation we have at GBSH. So please keep your eyes peeled for the webinar series. There'll be more interesting topics coming up in the future, and watch this space. So much to say, so little time. But thank you to everybody, all the panelists, all the audience, and also the facilitators, Angel, and the technical team at GBSH. Thank you so much. Bye, everyone.